Oh, shall we start? Okay. Assalamu alaikum. Hello, dear psychologists and psychiatrists. I'd like to welcome you to the Shezlong's online webinar that will be held on a regular basis. And we will start with the first event with the title CBASP for the treatment of chronic depression. Our speakers for today, Dr. Jan Klein from University of Lübeck in North Germany. Dr. Klein is a renowned psychiatrist and researcher in Europe, leading a research lab in his university with many PhD scholars, and has more than 180 publications. He has special interest in the psychological treatments for mood disorders and self-management intervention for psychiatric disorders. He's also a CBASP therapist, supervisor, and trainer. Dr. Klein is a co-founder of the CBASP network and contributed in the propagation of CBASP in Europe. I have honored having him as a supervisor. He's supervising my work with my CBASP patients. Philip, great having you here. And the mic is yours.
Well, thank you, Mohammed. I'm honored to have you as a supervisee, I suppose. And well, thank you very much for organizing this afternoon's webinar. And I'm not sure if you can see my screen yet. Mohammed, can you confirm?
Yes.
Okay,
yes,
perfect.
we can see your screen. And I guess we all can see your screen. You can proceed.
Perfect. Thank you.
Good start.
So my goal for this afternoon is to give you an introduction to CBASP. And really originally what we wanted to do is that I wanted to come to Cairo and teach you in person, but you all know that given the pandemic, that couldn't happen yet. And Mohammed and I have decided that it's better to have it as a webinar than not to have it at all. And I'm really looking forward to doing this with you this afternoon. And my agenda would be that I'll give you a brief 45-minute introduction into the CBASP model and also focus a bit on the evidence base for that model. And then we change gears a bit. And I want to give you an experiential approach and experiential introduction to the CBASP model. And also demonstrate one of the CBASP techniques with you in role play. So it'll be a lecture and questions, answers first, and then more of a workshop thing. And I hope that at the end, you will have a lively impression of what it's like to work with CBASP, and hopefully also have interest for working further with CBASP and learning further about CBASP. So first of all, CBASP was developed by Jim McCullough. And Jim McCullough has mainly worked with patients with chronic depression. It's been the main focus of his work. And his research focus has also been researching chronic depression, or as it's more formally called, persistent depressive disorder. So I will be talking about chronic depression this afternoon, but really what I'm referring to is what the DSM-5 calls persistent depressive disorder. And CBASP is really based on Jim McCullough's rich clinical experience in working with patients with chronic depression. And one of his main observations clinically was that these patients have a peculiar style of interpersonal interaction that could be summarized in a sentence of one of these patients: nothing I do, whatever I do, nothing will ever change. Whatever I do, nothing will ever change. And what McCullough observed is what patients are missing there is that their behavior has consequences in the interaction. So what he developed is the CBASP model a treatment model that is very well focused on the interpersonal interaction. So what Jim McCullough wants to teach his patients is the interpersonal contingencies in interpersonal interactions. Or to put it in simpler words, he wants to teach them this is the effects that you have on others. So patients will be able to choose, do I want to have this effect on the person I'm interacting with? Or do I want something else from the person I'm interacting with? And what do I need to do to get what I want from people I'm interacting with? So to sum it up, the work of CBASP is they start with the assumption, whatever I do, nothing will ever change. And Jim McCullough wants to help his patients with CBASP to understand these are the consequences of what I do. And I can choose, do I want the consequences I'm eliciting at the present, or do I want other consequences in interpersonal interactions? And what do I need to do to get these consequences? So the CBASP model is a model that's really focusing on these interpersonal contingencies. And the method CBASP was using is behavioral analysis. So what you'll see is a treatment that is very focused on behavioral analysis. It's a behavioral analysis for interpersonal interactions. So the model is rooted in behavior therapy, but it also takes inspiration from psychodynamic psychotherapies. And I think there's three central inspirations that CBASP takes from psychodynamic psychotherapies. The first is the importance of interpersonal interaction for mental health, but then also the importance for early interpersonal experiences for mental health. And thirdly, the importance of the therapeutic relationship for treating mental disorders. And it's very important for Professor McCullough that the CBASP model has been developed and tested mainly for the use in chronic depression. And what you see in this slide is the different causes of chronic depression, but I would like to give this a bit more of a practical focus and want to help you identify those patients that are most likely to benefit from the CBASP model. And I suppose what most of us do when we see a patient with depression, at first what we do is, in taking the history, is get the present depressive symptoms. So we have patients talk to us about what they're presently suffering from. And what I usually do after eliciting the current depressive symptoms, what I ask my patients is the question that you see here in the slide that we've also have psychometrically validated. The question we ask them is, when have you last experienced a period of 2 months or longer when you were more or less free from the depressive symptoms we have just talked about? When have you last had a period of 2 months or longer when you were more or less free from the depressive symptoms we just talked about? And what I'm getting at there is a remission criterion. So on a technical level, what I'm asking patients here is, when have you last met criteria for remission? And what I'm aiming at is, has this last period when they were meeting criteria for remission, has this been more or less than 2 years ago? So in taking the history, I first ask them about their current depressive symptoms, and then I ask them when they've last met criteria for remission, and what I'm aiming for is this more or less than 2 years ago? Because a chronic depression is a depression that is defined as lasting longer than 2 years. 2 years is the threshold for chronicity. And then at the third question, what you can ask them, okay, and in these 2 years or 3 years or 4 years, however long the patient's going to give you, in these 2 years, Did I understand you correctly that you suffered from depressive symptoms for more than 50% of the days? So for more than half the time have you suffered from depressive symptoms? Because that's like the minimum threshold to diagnose a chronic depression or dysthymia. Over the past 2 years, more than 50% of the days, and not more than 2 months with absence of symptoms. That's the definition. So first question, current depressive symptomatology. Second question, when have you last had a period of 2 months or longer where you were more or less free of your depressive symptoms? Third question, in this time frame, did you have the depressive symptoms for at least half the time? And then the fourth question is, when in your life have you first suffered from depressive symptoms? And what you're getting at there is this chronic depression with an early onset or a late onset? And an early onset is defined as an onset before age 21. And then the fifth question is, how often in your life have you had periods of 2 weeks or longer when you were suffering from depressive symptoms almost all the time, almost every day, almost all the time? So with your fifth question, you're aiming at the number of depressive episodes in your patient's life. And this is a very neat and practical way of assessing your patients for chronic depression, because chronic depression is the model, is the population that the CBASP model works best for. And the screening question for chronic depression has not only been psychometrically validated by us, but also by Mohammed over in Al-Azhar University in Cairo. Now, what I would like to introduce to you now is the model that underlies the CBASP treatment. And I'm going to demonstrate this model based on a patient example. And we call this patient Mr. Miller. And imagine you are working with Mr. Miller, and you have agreed upon some kind of behavior change with Mr. Miller in your last session. And now he's coming in for your next session, and you're greeting him, and you're saying to him, "Hi, Mr. Miller. I'm really curious, what was it like, what was it like with this behavior change that we agreed upon in the last session?" Mr. Miller answers, "I didn't try it, it's not going to work anyway." And what I want to give you here is one example of some patients with chronic depression who have this pattern of responding in a very hostile fashion. Others might respond, "I haven't tried it. I don't know, it's too hard." And what I'm giving you is these two examples are typical patterns of patients with chronic depression who are either reacting in a hostile fashion or with what McCullough calls a hostile submissive manner, where they avert eye contact, speak at a very low voice. So this is a typical interpersonal pattern of patients with chronic depression that we're also going to get into later in the workshop part of this webinar this afternoon. For now, let's stay with Mr. Miller, because well, before moving back to Mr. Miller, I just want to say one little thing, that this observation that patients with chronic depression are submissive, hostile, submissive, and hostile is not only a clinical observation that we are also going to make in a later section of the webinar, but it's also an observation that is empirically validated. There are a number of studies showing that compared to patients with episodic depression and normal controls, patients with chronic depression are more likely to behave in a submissive, and hostile style. And what I would like to explore with you now is, in some more depth, this model that underlies CBASP by understanding, why does Mr. Miller react in this way? Now imagine Mr. Miller, when he was growing up around significant others, mom and dad and others, that were emotionally abusive towards him. And it was a very pervasive pattern of emotional abuse that Mr. Miller grew up around. And a consequence of this emotionally abusive environment that Mr. Miller grew up in, what Mr. Miller did is he built this wall that you can see here on this slide. So he kind of built a wall around him to protect himself from this emotionally abusive environment. Now the trouble is that he's still using this wall now as an adult. And it's very difficult for you as a therapist to get through this wall. So I suppose when you are working with your patient, you are friendly. You are understanding if your patient has difficulties. You're supportive with those difficulties. But these characteristics, your friendliness, your helpfulness, your being understanding, these characteristics, they kind of don't get through this wall. They get pushed away from this wall. And what gets through this wall is what you're saying. Mr. Miller, what was it like trying the things we talked about last week? But Mr. Miller doesn't process what you're asking against the background of what he has experienced with you, your friendliness, your helpfulness, your being understanding. He processes this against the background of what it was like with his significant others. And he thinks, if I tell my therapist that I tried what we talked about last week, and that I experienced difficulties while trying, that then I lost courage and gave up. If I tell my therapist this, he's going to get mad at me and yell at me like my father always did. Like my father who always said to me, you're no good, you're a loser. So he processes what he experiences with you against the background of what he experienced in the past. And now, suddenly, it's easier to understand why he behaves the way he behaves, why he says, I didn't try this, it's not going to work anyway. He's trying to push you away because he's afraid of being heavily criticized for trying and failing. And the trouble with this is, if Mr. Miller has this pervasive pattern of acting in a hostile fashion, if Mr. Miller has this pervasive pattern of acting in a hostile fashion, even if others are friendly towards him, then he will pull for hostile reactions in his interpersonal environment. If he is hostile, others will react in a hostile fashion. And Mr. Miller will think, well, I always knew that. Whatever I do, nothing will ever change. People are always going to be hostile. It's been like that in the past. It's like that in the present. Now, there's one little thing that he's missing with this point of view. The little thing that he's missing is, one, you were friendly at the outset. And the other thing that he's missing is, he is the cause of the hostile reaction in his environment. The environment others might sometimes react in a hostile fashion towards him because he acted in a hostile fashion. And that's what McCullough calls perceptual disconnection. What perceptual disconnection describes is Mr. Miller fails to see that you are friendly, that you are supportive, that you are understanding. Mr. Miller fails to see that others are not always hostile towards him, but that they react in a hostile fashion because of his own hostile behavior. And this is what McCullough calls perceptual disconnection. And perceptual disconnection is like the central underlying pathology that CBASP aims to treat. And one aspect of this perceptual disconnection is the assumption of Mr. Müller. Mr. Müller is actually convinced. So one aspect of this perceptual disconnection is the conviction of Mr. Müller that nothing he does will ever change anything. Whatever he does, nothing will ever change. And this conviction, whatever I do, nothing will ever change, this conviction has been labeled by McCullough pre-operational thinking. So what McCullough does here, he likens this cognitive style of patients with chronic depression to pre-operational thinking kids growing up. And his assumption is that this pre-operational thinking derives from this emotionally abusive environment. And what I would like to do now is present some data to you that we have collected that supports these assumptions. First of all, we have developed a questionnaire that is also available in Turkish translation, by the way. And this questionnaire measures this pre-operational thinking. And this questionnaire is really simple. What it gives the participant is 20 scenarios, 20 interpersonal scenarios. And for each of these scenarios, the participant is asked to state how would they most likely react in this scenario. And he's given two options. One option is a formal operational thinking. I need to do this or that to solve this situation. And the other option is a pre-operational thinking stage. Nothing I do will ever change anything. Whatever I do, nothing will ever change. And here's one example. An appointment with a boss to discuss an evaluation, where the boss is criticizing. And the two options are, my boss will never appreciate what I do, and that the pre-operational answer, and I did have this and that problem, and I need to explain to my boss why. That would be the formal operational answer. And this questionnaire works as follows. Whenever someone gives a formal operational answer, you get 1 point, and then the points are summed up. And what you see here in the results is, if you give this questionnaire to a healthy control subject, they will get almost 20 points. So they almost always give the formal operational answer. If you give that questionnaire to a patient with chronic depression, they get around 11 points, but they only give the formal operational answer about half the time. They have pronounced pre-operational thinking. And the episodic depressives are in between. And what we have then looked at is it true that this pre-operational thinking derives from emotional abuse? And what we have found is that there is, in fact, an association between retrospectively reported emotional abuse and this pre-operational thinking. And this association is mediated by interpersonal fear. So there's evidence to support the model that I that I have shown you earlier, that this interpersonal fear mediates the association between early emotional abuse and this pre-operational thinking. And then what we've also looked at is this pre-operational thinking a characteristic mainly of chronic depression, or is it true for other disorders as well? And what we have done is we have compared patients with depression to patients with chronic low back pain and to patients with anxiety disorder, with panic disorder. And what we have found briefly is that this pre-operational thinking could only be found in depression, even though patients with chronic pain and patients with anxiety disorder have also been rated by their significant others as acting in a hostile submissive fashion. And even though patients with chronic low back pain and patients with anxiety disorder have also reported childhood emotional abuse. So this pre-operational thinking seems to be a specific mechanism in chronic depression that links childhood emotional abuse with hostile submissive behavior. So in summary, the assumption is that CBASP works best for patients who have reported early emotional abuse and who have fear-based interpersonal avoidance because they believe nothing I do will ever change anything. Whatever I do, nothing will ever change. And this results in interpersonal difficulties. So we have these 5 assumptions about for whom does CBASP work best and how does it work. And what I want to do next is show you some data that supports that this is a mechanism how CBASP works. And I will start by briefly lining out what we do in CBASP. And we will go into some more details of what we do in CBASP later in the workshop portion of this webinar, where I will demonstrate some of the techniques. And I will stick for now with the example of Mr. Miller. And I've already said that we believe in CBASP that building a trusting and collaborative therapeutic relationship will be difficult with these patients with chronic depression. We believe that building a trusting and collaborative therapeutic relationship will be difficult with these patients because of the experience of emotional abuse, emotional neglect, etc. And we also believe that it's easier for us to understand why they behave in this way if we know something about the emotional abuse and emotional neglect that these patients have experienced. And because we believe that, we start in CBASP with a technique that we call significant other history list. And the significant other history list is here on the bottom, on the left side of this slide. And what this slide shows is that all the techniques in CBASP are aimed at overcoming this perceptual disconnection. That's a central theme of CBASP. We want to help our patients understand this is a consequence of your current behavior. And if you want other outcomes, we will help you find out what you need to do to get other outcomes. So overcoming the perceptual disconnection is a central theme of CBASP. And we have broadly 2 sets of strategies in CBASP that are aimed towards this goal. On the left side of this slide, you see strategies that are concerned with the therapeutic relationship, your relationship as a therapist with your patient. And on the right side of the slide, you see strategies that are more concerned with interpersonal relationships of these patients in their everyday life. Now, the first technique I alluded to, the significant other history list, belongs to the therapeutic relationship. Because what you do with the significant other history list, you want to find out what are your patient's interpersonal fears that he brings into therapy with you. And what you do is you ask your patient, who were your significant others? And Mr. Miller, for instance, will name his father, and he will record the memories. He will recall the memories that I've already talked about. He will recall, my father always criticized me heavily when I made mistakes, and he was calling me a loser. And we will ask him, what is the stamp that your father left in your life? Mr. Miller will probably say, whatever I do is wrong. That could be a stamp that his father left in his life. And then we go through the same steps with all the significant others. And the goal is to find out, what is the transference hypothesis if we are working with this patient? And what we mean by transference hypothesis, we want to find out, what is the central interpersonal fear that Mr. Miller or your patient brings into the therapy with you? And you find this central interpersonal fear by looking at 4 important interpersonal domains: making mistakes, disclosing needs, closeness and intimacy, and expressing anger. And these 4 domains are called emotional hotspots or transference hotspots. And what you do is you identify a transference hotspot for your patient and try to find out, what is his interpersonal fear, what will happen if you reach the transference hotspot with your patient. And for Mr. Miller, it's, if I make a mistake around my therapist, he will criticize me like my father has always criticized me. So what you do at the beginning of therapy, you identify the central interpersonal fear that Mr. Miller brings into therapy with you, so you can be more careful around this central interpersonal theme that is so difficult for Mr. Miller, so that you can help Mr. Miller make a new experience around this difficult interpersonal theme. What you do then is you work with situation analyses, and we will work on situation analyses in the workshop portion of this webinar. But really briefly, what you do in the situation analyses is you ask your patient to bring in a sheet, which is also in your handout that you can also download. I will actually just post the link for you so you can download all the slides. And there's also this worksheet in the slides that you can download. And so the patient will bring in this worksheet. In this worksheet, he will report on an interpersonal situation that happened the past couple of days that was difficult for him. And what you do in this situation analysis, you go through these situations step by step, and you want to achieve 3 goals in situation analysis. You want to help your patient understand what are the consequences of his interpersonal behavior in this situation. And then you want to find out with your patient, what is a desired outcome for your patient in this situation? What would he like to do in this difficult situation? And then you teach him, how can he attain this desired outcome? How can he, what inner skills does he need to attain this desired outcome? But also, what behavioral skills does he need to attain this desired outcome? So it's really behavioral analysis of day-to-day interpersonal situations in your patient's daily life. And that's the main part of therapy. You're doing these situation analyses around 3/4 of your time when you do CBASP. But you also go back to the therapeutic relationship at times to help Mr. Miller experience that he is safe with you interpersonally. Because if you work on these situation analyses, the transference hotspot you have identified with Mr. Miller will come up eventually. For instance, with Mr. Miller, he was very good at bringing in these worksheets with the situation analysis, but one day he forgot. One day he forgot, and he was very, very upset about forgetting the situation analysis. And he came into the session and said, I'm so sorry. And I said, oh, what are you sorry about? I'm glad you are here. And Mr. Miller said, I'm so sorry because I forgot my situation analysis. And I'll say to him, that's not a problem. I heard you prepared your situation analysis, but apparently I forgot it at home. Yes, I forgot it at home, and I better had not come. And I repeat to him, well, I'm glad you came, but I'm noticing you're very upset. So what you see here is the transference hotspot has been activated. Mr. Miller is afraid I will punish him because he has made a mistake. I will punish him because he forgot his situation analysis. And what you do there is what we in CBASP call an interpersonal discrimination exercise. An interpersonal discrimination exercise is a step-by-step procedure whereby you help Mr. Miller see that he is afraid because others reacted in an emotionally abusive way when he made mistakes. So you ask him, how would your father have you reacted had you forgotten something important? And then you contrast that with your own reaction. How have I reacted today? What similarities and differences do you notice between how your father has reacted and how I have reacted today? And what possibilities arise now that you see that I have reacted differently to your father? And what hopefully happens there is that Mr. Miller will see, okay, I'm safe, even if I do make a mistake around my therapist. It's safe to come back here, even if I forget my situation analysis at home. And this felt interpersonal safety will help Mr. Miller work more collaboratively and more trustingly with you as a therapist. And would also make it less likely that he will react in such a hostile fashion when he's afraid of making mistakes. And I could go on, but these are just a few examples of how you can use interpersonal relationship in CBASP to help your patient build a trusting and collaborative relationship with you. Now that's the theory, and we will get into more practical details in the workshop portion of this webinar. What I want to do now, before we go to this workshop portion, I want to show you some data that this therapy model actually works. The first study I personally did on CBASP was a neurofunctional study, where we very briefly could demonstrate that CBASP also works on a neurofunctional level. And what we saw is increased amygdala activation at the end of treatment that we have interpreted as this wall coming down, that we think what this might mean is that patients allow this wall between themselves and others to come down and react more directly with the interpersonal environment. But more importantly, there's also a lot of clinical research on CBASP where the outcome is not neurofunctioning, but depressive symptomatology. And one study that we have been involved in was conducted by Lisa Schramm from Freiburg University. And here we have compared CBASP to supportive psychotherapy, client-centered psychotherapy, in the spirit of Carl Rogers. And briefly, what we have showed is that CBASP is more effective than supportive psychotherapy. And the main outcome time point was 20 weeks after the start of therapy. And the size of the effect at 20 weeks was a number needed to treat of 6. What this means is you need to treat 6 patients with CBASP for 1 additional patient to benefit in comparison to supportive psychotherapy. The other 5 would have also benefited from supportive therapy, or would have also gotten better regardless of what you do, or would not have gotten better regardless of what you do. And the number needed to treat of 6 is fairly good. That is the effect size that you also get with antidepressant pharmacologic treatment. So number needed to treat of 6 is good, but we in Lübeck were a study center for this study, and we were interested in finding out, are there subgroups of patients where this CBASP model works particularly well? And we looked at patients with comorbid personality disorder, comorbid social anxiety disorder, and we looked at patients who report early emotional abuse. And briefly, we found that CBASP works best for patients with social anxiety disorder, and it works best for patients who report early emotional abuse. And the number needed to treat here is 2 to 3. So you need to treat 2 patients for 1 additional patient to benefit from CBASP in comparison to supportive psychotherapy. And that's a huge effect size. That's rarely seen in psychiatric or psychotherapy research. So that's really, really good effect size. And we were also interested in how does CBASP exert its effect. And this is a complicated slide, and I'll walk you through it slowly. What you see here on the bottom is what I've already told you. On the left of on the bottom left, you see the group allocation, CBASP or supportive psychotherapy. On the right, on the bottom right, you see depressive symptoms at 20 weeks. And what the arrow shows is that CBASP is better than supportive therapy at reducing depressive symptoms at 20 weeks. And the top half of this slide is concerned with the question, how does this effect come about? And we looked at the influence of the therapeutic relationship and at the influence of change in interpersonal style of the patients. Because I told you that we believe that CBASP works because we can build a good therapeutic relationship with our patients in CBASP. And this good therapeutic relationship is a foundation for them to learn better interpersonal skills in their daily life. And this is what brings about the improvement of depressive symptoms. That's what we believe how CBASP works. And briefly, we could show this, this mechanism of effect in this study by measuring therapeutic alliance and by measuring changes in interpersonal difficulty, in particular changes in social inhibition, which is a proxy for hostile submissive behavior. And what we have found is those treated with CBASP report a better therapeutic relationship than those treated with supportive psychotherapy. Those reporting a better therapeutic relationship have a greater reduction in hostile submissive behavior, and those who have a greater reduction in hostile submissive behavior have a greater improvement of their depressive symptoms. So this study nicely shows that CBASP works through the mechanism that we believe it to work through. And I'm not going to bore you with the details of this slide. I just want to briefly mention that we have also looked at the subgroup of patients where these mechanisms work best. And what we have found is that these mechanisms work particularly strongly in patients who report early emotional abuse. So patients with early emotional abuse, those are those who have a particularly good therapeutic relationship with CBASP compared to supportive psychotherapy. So I hope that I've shown you that CBASP works best for the patients that it's supposed to work best for, and it works through the mechanisms that it's supposed to work through. So it works best for patients with chronic depression who have fear-based interpersonal problems due to early emotional abuse. It works best for this subgroup of patients, and it works through the therapeutic relationship and improvements in interpersonal function. There are many more studies showing the effectiveness of CBASP, and really the message of this slide is only that CBASP can be regarded as an empirically supported treatment if you take the criteria of the American Psychological Association. We could go into more details of this slide, but I suppose we don't have time for that right now. So what I've done now is I've hopefully given you a brief overview of CBASP. And we will now break for questions. But before we break for questions, I just want to briefly summarize what is most important to me. CBASP has been developed for patients with chronic depression. And it is built on the assumption that patients with chronic depression have interpersonal difficulties, are hostile, submissive, and submissive in their interpersonal behavior because they have experienced emotional abuse and emotional neglect in their childhood. And due to this emotional abuse and emotional neglect, it's difficult for them to appreciate the consequences of their interpersonal behavior on others. They have what we call perceptual disconnection. And CBASP was aimed at overcoming this perceptual disconnection by helping our patients understand that they're safe with us in the interpersonal relationship, but then also helping them understand what consequences their behavior has on others. And so they are better positioned to decide, do I want to have these consequences? Or do I want something else in my interpersonal interactions? And they're better positioned to learn with you how they can achieve what they want to achieve in their interpersonal interactions. And I've showed you that CBASP works, and it works best for patients who have social anxiety and report early emotional abuse, and it works through the therapeutic relationship and through improvement of interpersonal function. So thank you so far, and I'm really looking forward to your questions and to our discussion.
Thank you, dear Philip. Now is the floor open for some questions. If someone needs to write a question here in the chat, I will forward it to Philip to answer it, or a comment or something like that. And afterwards, we will have a couple of minutes break before we start the second part of this workshop with the practical part. Here's a question. I didn't quite understand the relationship between CBASP and comorbid personality disorders. That score means it's contraindicated, or that just doesn't work?
Yeah, that's a great question. Thank you. I have gone over that a bit too quickly, and I'm sorry about that. What the first row in this slide showed that CBASP and supportive therapy work equally well, irrespective of a diagnosis of a personality disorder. So many of the participants in our study had anxious avoidant personality disorder, obsessive compulsive personality disorder, and some also had a dependent personality disorder. And CBASP works very well with these patients. There is, regarding personality disorders, one little exception. I would advise you not to use CBASP on patients who have a predominant borderline personality disorder. So if borderline personality disorder is front and center with a patient, I wouldn't use CBASP with them. So if your patient engages in frequent self-injurious behavior, frequent suicide attempts, intense mood swings, I would use other therapy models that are better suited and specifically developed for borderline personality disorder. For all other personality disorders, if they're comorbid with chronic depression, you can use CBASP very effectively. Thank you for that question.
Philip, I have here a follow-up question on this particular point. I've mentioned that it works best better with the social anxiety, and any that suggests that it works with social anxiety disorder alone without emotional abuse or childhood maltreatment.
I'm sorry, Mohammed, you were a bit cut off. Can you repeat that question, please?
Okay, that was a follow-up question on this point. You have mentioned that CBASP works with social anxiety disorder and patients with depression, with comorbid social anxiety disorder with depression. My question is if there is any data suggesting that CBASP working with social anxiety disorder alone without emotional abuse or without childhood maltreatment.
That's a great question, and the short answer is no, there is no data on that. What we are talking about here on this slide is comorbid social anxiety disorder with early onset chronic depression. And to my knowledge, nobody has ever studied CBASP in patients who are only diagnosed with social anxiety disorder. And from a clinical perspective, I'm not so sure. I would probably, if my patient only had social anxiety, I would probably use other methods that are more narrowly focused on the social anxiety. Yeah, I would have to think about that, but it wouldn't be my first option.
Third question that came across, she asks, does this will work with persons started with OCD at 10 years old, then developed to depersonalization, somatic delusions after 31 years? Also, he treated with most of antidepressants. Apparently, she's asking about a patient that have comorbid depression and OCD.
Yeah. Well, I should probably talk a bit more about the way we have set up our treatment program here. We have a specialized treatment program targeted at chronic depression. It's a day treatment program. We treat 23 patients, and they have intensive individual therapy, group therapy, and nurse specialist therapy, in addition to occupational therapy and physical therapy. And we also have a social worker. And what we offer in this program is two different treatment models. We offer CBASP and we offer metacognitive therapy. So we also offer a different treatment focus. And if a patient came to our program and had predominant OCD, we would treat that patient with metacognitive therapy. So the decision whether to use CBASP or metacognitive therapy rests on three aspects. The first aspect is diagnosis, of course. And patients with chronic depression are more likely to get CBASP. And if they have predominant comorbid problems like OCD or generalized anxiety disorder, they are more likely to receive metacognitive therapy. The second question we are focusing on is, what is the predominant complaint of the patient? Does the patient predominantly complain about interpersonal problems? He's more likely to get CBASP. If he's predominantly complaining about worry and rumination, because that is the focus of metacognitive therapy, we offer them metacognitive therapy. And then the third pillar for our decision is the preference of the patient. So based on the diagnosis and on the presenting complaint, we make a recommendation for our patients and also give them written psychoeducational material. And then based on this recommendation and the written psychoeducational material, we make a shared decision with our patient whether to use CBASP or metacognitive therapy. So to sum it up, your patient with comorbid OCD, if the OCD is really pronounced, in our program would most likely end up in the metacognitive therapy treatment.
So, and I guess this answers the second part of the question. She asks if the patient wants to join the program, or at least to know if it is helpful for him or not. I guess you answered this, that the patient's preference is one factor also.
Yeah, and ultimately it is the deciding factor, actually.
Okay. So clearly the patient can join the program to see if it is helpful for him or not.
Yeah.
The last question, does this will work with teenagers started with sexual abuse at 7 years old and developed to porn addiction?
I will think about that. Well, there's a few things I would like to say on that. First of all, I think using CBASP in adolescents is sounds to me very reasonable. Many clinicians have done it, but it has never been systematically studied. So there's no trial of CBASP in adolescents. And I think that is one of the central, how to say that? In my view, regarding CBASP research, that is one of the central things that are missing. So if I would propose a CBASP study, I would propose a CBASP study in adolescents, because it's a really important field to focus on. I believe it's going to work there, but it has to be empirically proven. Now, if the comorbid porn addiction, did I get that correctly, as in pornography? Yeah. If the porn addiction comes into the picture, I would have to think a bit longer about that. And I suppose the main focus of my thinking would be what interaction does my patient avoid by resorting to porn for sexual satisfaction. So that is one thing I would focus on. Or more broadly, can you all see my whiteboard okay?
Yeah.
Yeah.
I think we can see your whiteboard. Do you want to write something down?
Yeah.
Okay.
Or maybe it's easier if I draw up this. I'll just explain it like that. I mean, porn addiction is just one of many examples of comorbid problems co-occurring with chronic depression. It could be porn addiction, it could be substance abuse, it could be panic attacks, it could be anything. Now, you may or may not decide to use CBASP, but if you do decide to use CBASP, you might want to think about, how do I integrate the CBASP work into dealing with the comorbid problems? And as I said, what we do mostly in CBASP is we use situation analysis, where we analyze daily interactions, where analyze one interaction in the daily lives of our patients. So if there's a comorbid problem, I would talk with my patient about, well, sometimes comorbid problems come on because we have interpersonal difficulties in our life. Like maybe you felt the urge to use porn, or the urge to use alcohol, or the urge to use, I don't know what, or maybe you had a panic attack after you had a fight with your wife or your boss or whatever. So what you want to establish first is the association between the comorbid problem and possible interpersonal triggers for that. And then you would want to do some psychoeducation. Maybe interpersonal problems trigger the occurrence of these comorbid problems. And then you go on to doing a situation analysis on this interpersonal problem, like a situation analysis on the fight with the wife or the fight with the boss or whatever. And then when you are through the situational analysis, you go back to what do you think? Had you solved the situation differently, would that have made this comorbid problem, this urge for using porn, urge for using alcohol, etc., would that have made it less likely? So in summary, you would try and find a connection with interpersonal problems, work on the interpersonal problems, and then go back to the comorbid problem to help your patients see that dealing more successfully with interpersonal problems can also help with the comorbid problem.
Thank you, DFF, for the detailed answer. I think we will go further for the next part of the workshop after 5 minutes break.
Sure, or would you prefer to move on straight away? Why don't we have it? Why don't we ask participants for feedback in the chat? If they prefer to, if they want to break, they just write break. If they want to go on, they write go on, and we'll see how people.
Okay, they're hearing you. They're hearing you. Okay, straight away, the first voice came in. Fine to go on. Go on. Okay, I would rather go ahead with the rest of the lecture. Okay.
Well, that's pretty obvious.
So, okay.
Okay, what I will do now is I would like to, what I would suggest is we might want to stop the recording because I'm going to ask you to